Everyone. It's great to see you. I'm Rabbi Victor Appel from Temple Emanu-El. Hopefully, we have had the opportunity to meet. Welcome to today's program, Why Do Ashkenazi Jews Have a Higher Risk of Breast Cancer? And we hope that you'll learn everything you need to know from genetics to surgery to information about BRCA. I am so happy to have been working with a great team of women, most of whom are members of the congregation, to put together this program. And they bring with them their not only their passion for this subject, but their professional backgrounds to help us learn today. I'd like to introduce one of our members of the congregation, Kara Barnett, who will be facilitating today's program. Kara is the director of anesthesia services at Memorial Sloan Kettering in Monmouth. She trained at Washington University School of Medicine in St. Louis. And she did her residencies at Albert Einstein Medical Center in Philadelphia and the Hospital of the University of Pennsylvania. So Kara has been working diligently with our group of presenters to put together a really great program for all of you today. So Kara, thank you, and I'll turn it over to you.
Thank you so much, Rabbi Appel. So I'm really excited to moderate this talk for you. We have 4 great speakers today who will discuss everything you need to know about BRCA and breast cancer. So just a few housekeeping notes before we get started. Each of our four and then we're going to have a question and answer session at the end. Because we have a lot to discuss in a short period of time, I'm going to try to play a little timekeeper here. But for you guys, in order to ask your questions at the bottom of your box. So just hit your chat box and you can enter your questions there. You can also have little chats there with the other attendees if you'd like. If you want to keep yourself anonymous to the other attendees on the conference, what you can do is actually decide who you want to send your chat to. You could hit just all panelists, or you can choose me, Kara Barnett, and just send your question to me. Let's get started with our first speaker. So our first speaker is Michelle Haar. She's been an active Temple member for 20 years and has served on the board of trustees and other numerous committees here through the years. Professionally, she is a licensed clinical social worker with a private practice in Cranford, where she provides therapies for individuals, couples, and families. She specializes in grief and loss. Michelle found out that she was BRCA2 positive in 2015 and had her prophylactic surgeries that same year. And she's really honored to come join us today and share her experiences. So let's get started with Michelle.
Good morning, everyone. Give me a thumbs up if you can hear me okay. All right, good. Well, thank you so much for joining us. I'm so honored to be part of this panel and so happy to share my story with all of you. I think I was asked to be on this panel not because my story is so unique or groundbreaking or some shocking twist. I think I was asked because it's the kind of story where it really normalizes this, because it really could happen to any of us. Whether you find out that you have a genetic mutation or you find out you have cancer, all of us are at risk. It's, in some way. We're not immune in any way. And I think that it's so important to have workshops like this because knowledge is power. And I felt really lucky that I was able to gain a whole lot of knowledge and use that to make the choices that I did. So bear with me. As Kara said, I'm a licensed clinical social worker. So Zoom and PowerPoints are not my specialty, but I'm going to try. So bear with me here. Okay. So I'm going to do this. I'm going to do this. Okay. I'm going to do this. Oh, there we go. Okay, so in my family, we use humor a lot. So my journey in this, my family, my husband has a wonderful sense of humor. And, you know, on one of the journey titles was, you know, Benjamin Button Boobs, which was, you know, my husband's humor, and, you know, kept a smile on our face through all of this. And so, you know, we sort of dubbed it Sisterhood of the Traveling Implants. This is me and my family. I don't know if you guys can see me. I have 3 beautiful daughters. I've been married for 25 years. My daughters are 23, 20, and 15. All of who have, you know, started at the preschool at the temple, and I got my final one going through confirmation right now. So like many of you, I really didn't pay attention to BRCA at all. And my first awareness that this gene even existed was because of the beautiful Angelina Jolie, who back in May of 2013, she wrote an op-ed in the New York Times. I wish I could say I read it in the New York Times, but I found out about Angela Jolie in People magazine. So, you know, that's sort of my my guilty pleasure. What occurred after that, so in 2014, I was just recovering from a broken leg when, and had finally, you know, was back on my feet, so to speak, literally, when on January 17th, I received this message from a cousin of mine. So I think you guys can read it. Hi, cousins, got some bad news to share. Looking for some information. My sister has breast cancer. It's early, but it should be okay. Turns out she's positive for BRCA2. This is a genetic thing and an important indicator for cancer. My mom is negative, so she got it from the Cascell side. Have you been tested? Please do so. If not, if you have been, can you share your results? So I'm gonna stop sharing for a second, and I'll go back to it. So that text changed my life. It was the beginning of January. Again, I didn't know anything about this. It was something that I was, you know, really not prepared for. And I had to sort of wrap my head around, like, what would that mean? I'm very fortunate that my best friend is my physician. And I sent her a text and I said, I found out that my first cousin is BRCA2 positive. The incredible thing about this story is that this is a cousin of mine who I hadn't seen in probably 30 years. So my father's brother, who is my uncle, who's her father, he and his wife had gotten divorced and they had moved. And they moved when she was young. And so, you know, sadly, we lost touch. The beauty of the story is that, you know, family is family. And when she got this, she didn't hesitate to reach out. So my journey began. So I'm going to go back to sharing screen. Bear with me again. Okay. So luckily she reached out and, oh no. Oh. How do I? I'm sharing screen, but it's not letting me. Hold on, I might have to go back in. So she reached out and sorry, I'm just trying to get this back up. Okay, that didn't work. See, I told you, never leave the therapist to do it. So she, sorry, I'm just thinking about what slides were next, so I don't run out here. So what ensued was me needing to make a lot of decisions. So I immediately called my girlfriend, who's my doctor, and she said, decide what you're going to do and go get tested and see. And so I got tested and found out I was BRCA2 positive. And then the real journey began. Meeting with doctors, trying to decide what to do. For me, it was a very easy choice. For me, it was a no-brainer to have a double mastectomy and to have my ovaries and my fallopian tubes removed. For me, that is a very, very personal choice, one I did not take lightly. I am a therapist and I specialize in grief and loss. And I specialize in grief and loss. And in that moment, there's a saying in my line of work, which is grief starts at diagnosis. And while finding out that your BRCA2 isn't a diagnosis, it is something that you don't know if it's going to lead to a diagnosis. I was very fortunate that I was cancer-free. I am cancer-free. But I really had to respect the loss of losing my breasts, of losing my ovaries, losing my fallopian tubes, and what that would mean for my children, in terms of them figuring out, do they carry this genetic mutation as well? So we told them, each of them in their own way, because each of them are different kids, and we told them in a very age appropriate way. One of the things that I was grateful for was this education that men are such an important part of this experience, and a lot of men don't realize that. My BRCA mutation is from the men in our family. Breast cancer is not and pancreatic cancer and melanoma, and there's an eye cancer that's associated with, and ovarian cancer. Well, the ovarian cancer, that's female, but there's all these cancers that men hold a link to. And I hope that part of why I wanted to talk about this also was just to remind us all that our men in our lives play an important role in our history. One of the things that got me through this was my support system. I picked a really great team of doctors. I was not scared to meet with multiple doctors to ask the questions I needed to ask. I was not afraid to get the help of my friends. My husband was incredible, my children. I really took advantage. The temple community was amazing. Meals, all of that good stuff. So do not do this alone. Whatever journey you are on, you do not need to do this alone. Please access, your support system, ask questions. Knowledge is power. And the more you know, the better you can provide for yourself. So I think my time's just about up. I had a really cute slideshow, but it didn't work and I pressed something. So again, I'm sorry that I got flustered in the middle, but thank you for listening. And there's going to be tons of great information that's going to follow. So thank you all.
Thank you so much, Michelle. Please remember, everyone, any questions, please put it in the chat box. So I'm going to introduce our second speaker. Her name is Angela Arnold Ross. She is a senior genetic counselor for the clinical genetic service at Memorial Sloan Kettering Cancer Center. Angela trained as a genetic counselor in her hometown of Melbourne, Australia, and then she got her Master's of Science in Human Genetics at Sarah Lawrence College in New York. She worked in the UK for 7 years and then joined us at MSKCC Clinical Genetic Service Team in 2008. She's part of the MSK Catch program, which encompasses comprehensive assessment, treatment, and prevention of cancers with hereditary predispositions. And she is currently seeing her patients in the tri-state area via the MSK Telemed platform. So take it away.
Thank you so much. Thanks for the lovely welcome. And thank you, Michelle, for sharing your story. Everything you hit on was such an amazing points that we put through in the genetic counselling appointments as well. Knowledge is power, support is so important, and I think this information morning is just so fantastic for so many people. It's so many steps in whatever process they may have, or even if they don't have a family history, this information is important. So I'm going to talk about the hereditary cancer and sort of touch on risk reduction, but Dr. Kirstein is going to talk about that later on today. But I am talking about the genetic side and the familial side of things. Now I'm just trying to figure out how I get to my next slide. There we go. So the goal of today is I'm going to talk about hereditary cancer, put that into perspective. I'm talking about hereditary cancer in the Jewish community. What are the unique risks? I'm going to talk about the BRCA1 and BRCA2 genes and their cancer risks and testing. I'm also going to talk about some newly described cancer predisposition genes that I feel it's important for the community that's here today, the local community, to understand that it's not just BRCA. And I want to talk about the pros and cons of genetic testing, why genetic testing matters, and knowledge is power is one thing I was actually going to say today, Michelle, and teamwork in my field is very, very important. And we have a fantastic team, at least that I work with at Sloan Kettering, that are amazing. So fact or fiction that most cancers are hereditary? Fiction. Most cancers are not hereditary. Most cancers occur by chance. Unfortunately, cancers are common. So a lot of people will have a family history of cancer, but it does not mean that it's definitely due to something that you inherited from your mother or your father. We see in genetics, in cancer genetics, I'll see all comers and take a family history to see where someone might fit into this pie chart example. And the proportion there, the 5 to 10%, they're the proportion of families that we see that we identify a genetic change, a genetic mutation in a gene that's been passed down from their mother or their father's side. Very quick review. You have 2 copies of every gene, one from your mum, one from your dad. The only difference between males and females is the X and Y for males and XX females. The genes make proteins, and proteins do the function in the body. So the genes that we're talking about today specifically are cancer predisposition genes. Their role in the body is not who you look like, what you look like, who you take after. They are the genes that work in the cell to prevent cancer from developing, very simplistically. So when someone is born with a mutated gene or a gene from mum, again, I'll say or dad, as Michelle, and we're going to highlight today, it's not just about females, mum or dad, they have 50% of that genetic protein that's meant to be there. That can get people through life without any problems, but then it does predispose people to certain gene-associated risks. So just having a mutated gene in most of these genes does not mean you're going to develop cancer by any means, but it might put you at risk. And that's why you meet with genetic counselors, genetic professionals to understand that, and for you and your family. So what are the features of hereditary cancer? So we take a detailed family tree or family history, we also call it a pedigree, and we take down the history of unaffected and affected family members to get an idea of what that family looks like. We look for multiple generations that are affected with cancer, more than you'd expect. Multiple cancers in someone as an individual. So if someone has breast and ovary cancer, if someone develops bilateral breast cancer, if someone has colorectal and uterine cancer, that sets off red flags to maybe genetic testing is appropriate. We looked at cases that are diagnosed earlier than you'd expect. So for example, breast cancer at the age of 30, colorectal cancer at the age of 25, ovarian cancer pretty much at any age, but rare cancers as well. Male breast cancer is very uncommon, very rare, but it is a little bit raised in the BRCA population and BRCA carriers, I'm sorry, and I will go over that in a minute. And ovarian cancer is considered sort of a rarer cancer as well. Pathology of cancer, that gets into a bit of the minutiae, but when I speak to families, I try and get as many pathology reports, specifically of ovarian cancer and other cancers as well, because that can kind of lead us to or guide us to what sort of testing or syndrome a patient may or may not have, if there's any other genetic tests we should consider for that family or patient. And Ashkenazi Jewish ancestry does play a role in our risk assessment, or asking ancestry plays a role in our risk assessment. So what about hereditary cancer in the Jewish community? So fact or fiction, is cancer more common in the Jewish population? That's actually fiction. Cancer is not more common in the Jewish population. What is more common is the hereditary version of cancer. So there was a big population of people thousands of years ago, and due to population decrease, flood, famine, migration, isolation, that population shrank. And then as time went on, the population increased. And for whatever reason, in certain people, not just the Jewish, but for this talk with the Jewish population, there are certain founder mutations in certain genes that survived the population decrease. There was no advantage for that. I don't know if you've heard of sickle cell disease, but in that particular syndrome, there is a survival advantage for malaria. But for these genes, there's no survival advantage. The generations later, these founder mutations were just expanded, and so certain populations have these founder mutations in certain genes because of that example, and that presents special opportunities for screening and prevention. And as Michelle said, knowledge is power. I really like that verbiage, not to diminish anyone and what they go through, but in this day and age, we can manage people's risks, we can hopefully prevent cancers, we can identify people at risk. So for this talk, what genes have founder mutations in the Jewish community? BRCA1 and 2, I'm going to be talking a lot about that today. There are a couple of other genes I did want to mention because in the role of genetic testing now, it's commercial. Not everyone's coming through genetics. Doctors have access to it that don't normally do genetic testing. And so some people are coming to us with tests from outside where they've had genetic testing for mutations in genes that we wouldn't normally have necessarily tested them for. And we've picked up these not necessarily insignificant, but incident findings. And I feel that's important to mention. And I'm not going to go into a lot of detail for time today, but I can answer questions later. So I'm going to mention that in a minute. But BRCA1 and 2. So hereditary breast and ovarian cancer, Michelle, that's probably one reason why a lot of people feel this is female orientated, and it's actually probably misnamed. It is called hereditary breast and cancer, ovarian cancer syndrome. If you have a familial or germline genetic mutation you've inherited from mum or dad. But it's not just breast and ovarian cancer. So that is something we'll talk about in a minute. These are the three founder mutations. There are 2 mutations in the BRCA1 gene that are more prevalent and 1 in the BRCA2 gene. Dr. Kenneth Offord, the chief of the service, he actually identified the BRCA2 mutation here. But these 3 make up the most common mutations we'll find in someone of Jewish ancestry who presents with a strong family history or of cancer. And in the general population, about 1 in 40 will carry one of these 3 mutations. So it's pretty common in the community. And that's why I like to do these presentations, to make people aware. And it doesn't mean you're going to have a mutation by any means, but it means we can have a discussion if testing's appropriate. Fact or fiction, is BRCA1 or 2 mutations only affect women? As we've already said, it's fiction. Sorry, can someone please mute the thing? Sorry. Fact or fiction, BRCA1 and 2 does not just affect women, it affects men as well. I'm sorry. And can BRCA1 or 2 mutations be paternally inherited? Fact, they can be paternally inherited. So the truth about BRCA1, 2 in men and women, and also, I know for time, I just want to get through my slides today, but I can, again, at question time, both men and women are at increased risk for certain cancers. The cancer risks do differ by gender, and unfortunately, women are more likely to be affected because it is predominantly affects the female breast tissue and the ovaries. But it can be passed down from men and women, and there are male-associated risks that we are learning a lot more about. Prostate cancer, we are determining, can be a little bit more aggressive in BRCA carriers, but there are targeted therapies, so there's also a plus side. Pancreatic cancer, as Michelle mentioned. We can see melanoma, ocular melanoma a little bit, and I'll talk about those in a minute. Sorry, next slide. I just put these slides in not to confuse you, just to give you an idea about the breast cancer risk in BRCA carriers. So BRCA1's blue, BRCA2 is red. There are a little bit of difference between the 2 genes, but we still do the same risk reduction and management strategies or offer them. But as you can see, the BRCA1 carriers tend to have breast cancers occurring a little bit younger than the BRCA2 carriers. And if we think of this as the age of population risk, we're definitely seeing BRCA carriers can have risks under the age of 50 and more risk of breast cancer in their life due to the predisposition. Ovarian cancer risk is the same. It's very rare in the population. BRCA1 carriers, it's about 2 to 3% under the age of 50, which is double the population risk, but it's still elevated and it increases as the age goes on. And BRCA2, the carriers have a high risk of ovarian cancer in their lifetime as well. And again, the ages, while sort of postmenopausal, we don't always take that chance when it comes to risk reductions options, as Laurie will talk about soon. There is a risk for second breast cancers, third breast cancers, unfortunately, in BRCA carriers, because the BRCA mutation is, if it's inherited, is in every cell of the body, that's in every cell of the breast. So there is a risk of developing another cancer primary. It is not a certainty. I just want to highlight that, but there is elevated risks, and that's what we talk to patients about. We mentioned male risks. There are male risks associated, specifically, not many people have heard about male breast cancer. It is still low if you think about it, like 93% of BRCA2 carriers will not get male breast cancer. But if you think of the population risk of like under 1%, that's very significant increase. And it is increased in BRCA1 carriers as well. Prostate cancer, I do want to highlight this because this is very important to get our male BRCA carriers in for their screenings as appropriate, as directed by their doctors and genetic specialists, counselors, doctors. The risks do differ between genes a little bit, but still both genes provide increased risks for prostate cancer over someone's lifespan. Not often younger necessarily, can be a little bit more aggressive, but we do recommend screening and surveillance start around 40 for these carriers. So males are important too. So the risk reduction and surveillance recommendations, it's teamwork. I'm a genetic counselor. I discuss recommendations, as do my colleagues, with patients and our genetic doctors. And then we refer to our expert physicians who are used to or are experts in following people at high risk for the BRCA or other gene-associated cancer risks. We refer to our RISE program, Risk Assessment, Imaging, Surveillance and Education program, which is a high-risk breast cancer screening program, which Dr. Kirstein is a major part of. And I'm part of this amazing new program called CATCH, where we have combined, we provide a comprehensive assessment, treatment and prevention of cancers with hereditary predispositions to help patients navigate through their cancer screening and risk reduction options. As you might have gathered, people are at risk for these cancers, not all of them, but we do have management strategies, surgical strategies. We now have Dr. Robert Sidlow, who sees our male BRCA carriers, which has been very important, I think, for the men to have a male to talk to. Not that they don't mind talking to females, but that's been an amazing addition to our team. And Dr. Alicia Latham and Lysiana Millie, our APP, help coordinate our high-risk patients for referrals to other people like gynecologic surgeons, GIs as appropriate. So we really work as a team at Sloan, and there is a pancreatic tumor registry I'm not going to go about today, but we have a plan for everyone at risk. But it's not just about BRCA 1 and 2. If someone comes to me now in 2021 with an early onset breast cancer of Jewish or not Jewish ancestry, or a high risk of ovarian cancer or breast and ovarian, we actually now test for mutations in genes in 9 genes linked with familial breast and ovary cancer. Again, not going to go into these today for time. I'm happy to answer questions, or go and meet with your genetic counselor if you had testing in the past and it was just BRCA. Even if you're BRCA positive and there's a strong family history on the other side of the family, or there's still a very strong family history and you've only, because traditionally we just tested for that mutation in the family, it's not unreasonable to go back and meet with a genetic counselor. We rarely, but do find patients who are carriers of more than one predisposition. It doesn't make it any worse, but it does have impacts for future generations and risk assessment. So again, encouraging you to have follow-up with a genetic counselor, consider update testing if appropriate as determined, and it's not just BRCA 1 and 2. Briefly, I don't know how I'm going for time. If someone wants to ping me, CHEK2 is a gene that we do find on these panels. It does provide an increased risk for breast cancer. It's not as high by any means as BRCA1 and 2, but it is a gene that we are finding more patients are carriers of. There are a few common mutations in the Ashkenazi Jewish population. We do see it in other populations as well. It provides a mild breast cancer increase and a little bit of a colorectal cancer increase, but we are identifying carriers of these mutations because people are doing broader panels now. I'm not going to go into the management again for time. Lynch syndrome. Lynch syndrome is actually very common in the general population. About 1 in 275 carry it versus 1 in 400 to 1 in 800 for BRCA1 and 2, a hereditary breast ovarian cancer syndrome in the general population. So it's not as talked about, but it does provide risks of ovarian cancer, which sort of links into the discussion today and overlaps with breast BRCA testing actually. And there are some common founder mutations in the Jewish population. I see a lot of the A636P. Don't forget, I'm at a cancer hospital, which is why I see a lot. And these other mutations as well. But we don't just test for these. If you came to me and you're at risk for Lynch syndrome, or there's an indication for testing, we test you for a broader panel, including all of these genes. It does come with management. Again, I will not go into this today, but that is something to discuss with a genetic counselor. If you are at risk, if you have Lynch syndrome or are found to have Lynch syndrome, surprisingly on a panel test, which I have had happen recently actually in a family that we would not have picked up normally. APCI 1307K. I know it's a tongue twister. This specific mutation comes up quite often incidentally on these tests that people are having either with us outside of Memorial, because again, testing is broader now than what it used to be. It's a gene that causes a little bit of an increased risk, a moderate risk for colorectal cancer. It occurs in 6 to 10% of the Ashkenazi Jewish mutation. It's normally, if you Googled it, and I don't recommend Dr. Google, you'd see it calling something called FAP, where you're carpeted with polyps. That is not it. You have to be made aware this variant is a moderate risk, not to diminish anyone who carries this and has a family history, but it does provide risks. It does provide recommendations if you're a carrier. So again, I recommend genetic counseling or discussions with a genetics professional if this pops up on any screening. Also, just wanted to quickly, a PSA note, we've recently started colonoscopies in the general population, not high risk, to 45 years instead of 50 every 10 years. And this is going to be different to any carriers who are at risk for colorectal cancer from a familial sense. So fact or fiction, if genetic testing is negative, you are not at risk for cancer. Fiction. While a negative result might be reassuring, and I never take that away from my patients, we still have a risk for cancers in other organs as a population, for population risk, be it prostate, breast, gynecologic, lung, melanoma, things like that. So we warn patients about that as well. You still may be at risk for cancer based on family history alone. Look, we're pretty smart these days, but we don't know everything. And the genes we know today are different from the genes people tested for back in 2008, for example. So there is always knowledge. So I always recommend follow up with your genetic counselor every couple of years if there's a strong family history. Follow up with your genetic counselor or your doctors if you're BRCA or other gene positive for updates about what you'd be doing, because we're improving our surveillance, our risk reduction options, our testing pretty regularly now actually, but it can take years. So to always check back in. One big thing, if you do have genetic testing outside of a genetic risk assessment from a genetics professional, there are variants of certain uncertain significance that can be identified. So when you're testing, if you think of testing like a book, you're looking for a spelling mistake in that book that's that gene that is a human gene, right? That we generally know what it's going to look like. So the BRCA gene, we know what it looks like. We're a human. It's got the sequence. It's got the letters. You could be positive where we find a mutation, and the extrapolated example is someone's come and ripped out chapters 3 to 6 of a 20-chapter book. That's a positive result. That's a predisposing result. You could have a negative result where you do not have a mutation in any of the genes tested for, but you could get a result that's in between. It's a change in the DNA that's there. If I tested you today, next week, in 10 years, it's a DNA change that is possibly in the family, but we don't have enough information to say it's predisposing to cancer or gene-associated risks. It's benign. A lot of those get downgraded, but we're testing so many genes now we've never tested before. These come up a lot. So it's important to touch base with myself, with genetic counselors, if you get one of these and don't quite understand what that means. The benefit of testing, I'm not going to talk about it because Dr. Kirstein's going to, but risk management, medical management, screening, surveillance, medications. We could inform families. And as Michelle said, I'm such a proponent of telling family members about these results. It breaks my heart when I see families that don't. I've seen a cousin, and then 10 years later, a cousin who, again, with HIPAA, we can't share information, but I put it together. There was a BRCA mutation. It's not, and it breaks my heart. So families don't share information. And thankfully for Michelle, her family did. And I really, but all we can be as paternalistic as we can, but sharing information can save lives, and it's so important. We can define risks. We can take risks off the table for some families. If they're a true negative for a full risk assessment, sometimes we can back off a little bit. And then there's reproductive considerations as well. And again, a bit too much to go in today, and targeted therapies. So I want to thank my amazing team of clinical genetic service. We have 21 genetic counselors now, 7 doctors now that we work with, and my amazing team, Dr. Kirstein, her colleagues, the RISE team, our Catch team, everyone I work with at Sloan, I really love, truly. And I will save this for questions later, but thank you so much.
All right, thank you so much, Angela. I'm going to introduce our next speaker. She is my colleague and dear friend, Dr. Laurie Kirstein. She is a Temple member and breast surgical oncologist at Memorial Sloan Kettering Cancer Center. She did her surgical training at Albert Einstein and her fellowship in breast surgical oncology at Mass Gen Hospital. She's the current chair of the Education Committee for the Commission on Cancer through the American College of Surgeons. Her research interests include reducing pain and opioid use after breast surgery and educating women on their surgical choices for breast cancer. All right, all yours.
Thank you. So I have some slides, but they're more anatomic. And I thought what I would do today is just really talk to you like I talk to my patients. You've heard so much good information so far. I mean, Angela provided so much information. And if we had the same talk, even 10 years ago, there wouldn't be as much information that's available right now. And it makes all of our jobs more interesting and a little bit more difficult and challenging. And one of the things that Michelle brought up, which I thought was really good, is how you find out this information. So by the time you get to me, a surgeon, there are people who have been told that they have a BRCA mutation, but there's also people who come with breast cancer. And after meeting with them and reviewing their family history, we send them for testing, and they find out that they harbor a BRCA mutation. And one of the most important things to remember when you're diagnosed with a BRCA mutation is that there are choices, and that it may take a little bit of time to process that information, and that while it feels very acute at the moment and very, very scary, that it's okay to sort of step back and educate yourself and get more comfortable with what choices you want to make. And so, as you heard, the BRCA mutations are predisposing to both breast and ovarian cancer. And BRCA2 in particular also predisposes to pancreatic and colorectal cancers and community cancers. And so when we see these patients, we make sure that we actually send them to a genetic counselor so that they can become informed about what screening tests they might need, in addition to breast, for example, that I do, or ovarian risk surgery or following for ovarian cancer. Somebody posted in the chat incredibly astutely, don't rely on commercial genetic tests like 23andMe. You must get a real genetic counselor and testing at one of these licensed labs. And what that does will give you a particular mutation, but they also collect information over time. And so let's say you've got a variant of uncertain significance that could be reclassified if you tested with a really good lab. And so it's important to always see a genetic counselor either before or after you get your results and make sure that the quality of the lab is good. And so what if you're diagnosed with a BRCA mutation? What does it mean? Well, a few of the things that we talk to our patients about is there are really 2 options once you're diagnosed with a mutation. One is high-risk screening, and the other is prophylactic surgery or risk-reducing surgery. And each individual has to come to a decision for themselves in the time that's important to them. And so it might not be that somebody gets diagnosed with a BRCA mutation and suddenly wants to have everything removed right away. And it's important to reassure them, or to reassure people, that studies have basically shown, at least for breast cancer, that if one engages in high-risk screening, and we can go over what that is, that if someone is diagnosed with a breast cancer, that breast cancer will be diagnosed at a much earlier stage, less likely to need chemotherapy, and have good overall survival. And so it's okay to engage in high-risk screening for any period of time. And there are people who will engage in high-risk screening until they're emotionally ready to do their prophylactic surgery, or some people never do their prophylactic surgery. And the other important information to provide patients is that the younger you're diagnosed with your first cancer, breast cancer, associated with a BRCA mutation, the more likely you are to develop a second one over the course of your life. And that's just simply because there's a longer life. So if you got cancer in your 60s or 70s and found out that you had a BRCA mutation, it's actually unlikely that you'd get a second breast cancer over the course of your life. And so perhaps that information would factor into a decision of high-risk screening versus prophylactic surgery. So for high-risk screening, and I'm going to primarily focus on breast and ovarian cancer because that's what the BRCA mutation is usually predisposed to. Ovarian cancer is a little bit tricky, and I'm certainly not a gynecologic oncologist, but I have my colleagues at Memorial who we work with very closely. You've heard about the CATCH program, which screens patients, and then we have our gynecologic oncologists who will talk about the screening and risk-reducing surgery. So the screening, some people will do transvaginal ultrasounds to look at the ovaries, and some people will do an enzyme in the blood called CA-125. And the unfortunate part of both of these screening modalities is they're not very good. So that CA-125 is secreted or expressed by some ovarian cancers and not others, so it's not very reliable. And the ovarian cancer associated with BRCA, but also ovarian cancer in general, by the time you can actually see a large ovarian cancer, it's usually about stage 3. And so what we want to do is be able to either find them earlier or be able to offer some risk-reducing strategies. And so in the past few years, it has been recommended that by age 35, or when somebody has done childbearing, that one removes the area that causes the cancer. And so at Memorial, they have started a project where they have removed the fallopian tubes. The fallopian tubes are thought to be the primary source of ovarian cancer for BRCA mutation carriers, and then to remove the ovaries later on, maybe 5 or 10 years later, so that one can still get the benefits of estrogen if you're a woman, like on your bones and on your heart. The risk of developing ovarian cancer for a BRCA mutation carrier is about 40 to 60% over the course of their life. This risk-reducing strategy will take that cancer risk down to less than 5%. So let me focus on breast cancer because that's my specialty. And the screening strategy for breast cancer patients consists of doing screening twice a year instead of once a year like the general population, with breast exams twice a year. So once a year, a patient will normally get a mammogram and ultrasound, and 6 months later they'll have an MRI, and they will be examined at both of those times in case there's a mass. And we actually ask women to examine themselves each month in between, because sometimes with the BRCA mutations, especially BRCA1, someone can develop a breast cancer in between screening, what we call an interval cancer, and then they should come in and get worked up. This is a very successful strategy, and most women do very well with this strategy. My experience is that once they start to have biopsies or get some abnormal studies, the anxiety starts to increase, and that's when we start to talk about risk-reducing surgery. And not to say that there aren't women who find out they're BRCA positive and want to do the risk-reducing surgery right away, and either are completely valid pathways. It really is an individual decision. So what are the risk-reducing surgeries for breast cancer? Well, we do bilateral mastectomy, and that will take the risk of breast cancer from 60 to 90% over the course of their life down to less than 5%. So if you think of the average woman walking down the street without a BRCA mutation, they have a 12% lifetime risk of breast cancer. After risk-reducing surgery for BRCA, it's less than 5%. So that's less than the average woman walking down the street. There are different types of mastectomies. There's mastectomies without reconstruction, in which we leave a woman flat and she can have a prosthesis. Insurance companies will pay for prostheses and prosthetic bras. There are skin-sparing mastectomies, in which the nipple and areola are removed, but we leave as much of the skin as possible, a skin envelope. And there are some women who choose this option because they want to take the risk down as much as they possibly can, and leaving the nipple leaves about a 1% increase in risk over the course of their life. Cosmetically, the plastic surgeon also has to let you know if you're eligible for what we call a nipple-sparing mastectomy. Sometimes the nipples can be preserved and sometimes they can't. And in terms of reconstruction for breast cancer, there are basically 2 kinds of reconstruction that one can have. One is implant-based, and one is tissue-based, your own tissue. Implant-based reconstruction can be done in stages. Either an implant can be put in right away with some synthetic material to sort of hold the implant in place, Or the plastic surgeon can put in something called a tissue expander, where it goes behind the muscle and slowly stretches out the muscle, and then eventually an implant is placed at a later date. The other is tissue-based reconstruction, where these days people will read about the deep flap, which is basically a tummy tuck. They take your fat from your stomach and dissect out the blood vessels. And once the breasts are removed, we do leave a lot of skin in place to protect the nipples in place. They'll actually take your own fat and put it back in under the tissue and sew in the vasculature, the blood vessels. And again, it's a very natural looking and feeling, both are actually very natural looking and feeling reconstructive surgeries. And the important piece of all this is really just to be able to talk to your patients and allow them to process this information. And as everybody else has said, to gather the information about the surgeons and the facility that you're working with, to make sure that you're comfortable, because the truth is it's a relationship and it's a lifelong relationship. And so what we do is we will refer to our RISE high-risk breast cancer screening program, or CATCH, the ovarian cancer screening program. If necessary, we'll send back to the genetic counselor to make sure that patients are being worked up for example, colonoscopies, for the pancreatic screening program. And when enough a patient is ready to do, and we order all the imaging, we follow them, we examine them. And when enough a patient's ready to do the surgery, we have them meet with the plastic surgeons to talk about the process, make sure they're educated about what to expect postoperatively. It's a big surgery, but for some women, it's an incredibly relieving surgery. But it's a personal decision. So I want to say thank you so much for inviting me to be on this panel today. I'm very new to this synagogue, and I'm very excited to be part of this community. I'm not new to some of the panel members, but it's been such a pleasure to get to know everybody. So I'm open for questions later. Thanks so much.
Thank you so much, Dr. Kirstein. So our last speaker, but not least, is Lauren Hammer. She's been an active Temple member for over 20 years. She's been a volunteer on various Temple committees. Lauren is a licensed clinical social worker, has a private psychotherapy practice in Westfield for the past 20 years, and has an executive coaching firm, Hammer Leadership. Lauren's area is focused in on family systems, and she works with individuals, couples, families, and organizations around topics related to emotional balance, self-confidence, communication effectiveness, and personal leadership. So there you go.
Thank you. Hopefully you can all see me. I'm working with 2 different laptops now. Okay, thanks. So I'm really happy to be here. Thank you.
We lost your sound, Lauren.
There, can you hear me now? I think someone muted me. Hold on, okay. Sorry. So thank you for being here, for having me be here, and for everyone attending. Like I was said, I've been part of the Temple community for 20 years. Ironically, Michelle was my introduction to the Temple when my daughter was 3 months old and I joined a new mommy's class. So it's kind of, I guess, an unfortunate irony that we land here 20 years later. So as a clinical social worker and in my coaching work, I spent a lot of time working with families, talking about generational patterns of behavior. What I hadn't considered, however, is the medical aspect of this. So I'm just trying to get my screen to work. It's not working right. So I hadn't considered the medical aspect of this until it kind of came glaring in my own life about 3 years ago, of which I procrastinated until a year ago to deal with. So I'm going to screen share to help with this. So so this has turned into my mantra. I got this, since all of my BRCA knowledge has come to light. And so what I realized is what I don't know can hurt me. So what I had done about 10, 12 years ago, actually, is create this family diagram, a family tree. And when I saw a geneticist, she had similar information. So I am down here in the bottom right. And everyone in pink is more my immediate family. So my brother and my sister's on here, hello. And my parents, where you see the X's, that's someone who's deceased. So I created this diagram. And then what I realized is the person who circled my grandfather, I knew nothing about. So to the right is my grandmother. She was an only child, but my grandfather, I didn't know if he was. And I got really curious. My siblings and cousins and other family members No one had information. My grandfather died when my mom was 13 of unrelated causes of a heart attack. And they just never kept in touch with that side of the family. So I knew nothing about him, couldn't find anything online as well. My mother, who had passed away about 25 years ago, she died of unrelated BRCA-related illnesses as well. Her sister to the left of her with the X, the circle with an X, she did die of pancreatic cancer about a month before I was born, but never had anyone, or at least I had never given consideration that this could be something BRCA-related once I initially learned about BRCA. And my father had had pancreatic cancer, not his cause of death, and overcame it, but also never gave any consideration to that as well. It all changed back in 2018 when I got a random phone call. It was an email followed by an immediate phone call from this woman, Melissa, who turned out to be my mom's first cousin on her dad's side. Now, if you can see in the blue, it says Irving, that's my grandfather. So I just took that section of the diagram and expanded it here. And with that phone call, I found out that my grandfather had 3 other siblings. And I found out that his younger sister, Marilyn, had died of pancreatic cancer about, 15, 20 years ago. And then I found out that my great-grandfather also died of pancreatic cancer. And Melissa had told me that she had recently had ovarian cancer and was doing well, which meant that her mother, who did not die of a BRCA-related death, also had BRCA. So in this phone call, I suddenly put together that I needed to do something. Now I had 3 generations of BRCA in my family history that I had never known about. And I now knew that I was suddenly at risk of getting it. And then I also put together that my aunt, who died of pancreatic cancer, probably had BRCA, which meant that my grandfather probably was a BRCA carrier, which goes along the lines of what people were saying earlier about this can run through the line with men. So I then didn't know if my mom had the BRCA mutation. And that was the big investigation that I had to deal with, but I procrastinated for a while, and then the pandemic hit, and I finally moved forward and got tested. And so last November, just about a year ago, I found out that I have the BRCA2 mutation. I also found out that I have APC and ATM. And so while just during this, I checked my genetic report, and I do have that exact APC mutation that was just discussed, I think it was I137K. So in addition to the BRCA, I'm also at greater risk of colorectal cancer. And then the other mutation, I don't know much about, and it's an unknown variant. My brother and sister then got tested, and my sister found out that she too had BRCA, and my brother as well. So now the 3 of us, so we concluded that my mom had BRCA, the BRCA2 mutation. And so to me, I was a ticking time bomb, and I wanted to then have surgery. I'm going to just not screen share for a moment. Well, I'll stay there. So I decided to have the BRCA, I decided to have the risk reduction surgery, and I had a bilateral mastectomy last February with the tissue expanders. There was over the muscle, not under the muscle. And then in April, I had the bilateral salpingo oophorectomy, and I also had a hysterectomy just to help me with hormonal replacement therapy. And then I also had the exchange, which was my reconstruction. So my sister wanted to take a different approach, and she didn't want to do a mastectomy. She wanted to do the surveillance. So forgive me for talking about you, Alicia. And so she ultimately found out we had the GYN surgery. We both had it, and her pathology came back that she was sick, that she had precancerous cells. So her surgery was life-saving surgery, according to my gynecologist oncologist. So this cousin Melissa, who randomly found me just to make sure that I knew that I could have the BRCA mutation, as can my siblings, definitely saved, in my opinion, and what I was told, saved my sister's life. She then later found out that she had DCIS, which is stage 0 breast cancer, and had her bilateral mastectomy not long ago, and is currently healing from her surgery. And she did the deep flap. So 2 sisters, very different approaches, and both positive outcomes. And then my brother is BRCA2 positive as well, and he's doing all the surveillance. because there's no surgeries for him to prevent anything. So this is just, I photographed everything because I love to take pictures. So on the left is me taking the genetic testing or going to the geneticist, and that's what my genetic testing looked like. Because of COVID, they sent me home with a spit test. And then I saw lots of different doctors. I found out in November, I decided to take December to just process everything. And in January, I went gangbusters. I saw 4 different breast surgeons, 2 different gynecologists, oncologists. I've since consulted with 4 different GI doctors. And I landed with Sloan Kettering for all of my doctors. I'm now part of the RISE program that was being discussed, and I'm on the Memorial Sloan Kettering, or I'm about to be on their pancreatic cancer registry as well. The bottom are my surgeries going into pre-op, the first surgery. The middle picture is me the next day after my bilateral mastectomy, and then going into the second surgery. And then the right one is me leaving after the second surgery. For anyone that might find themselves in this position, I'd like to tell you that I had what I'd like to think of probably as the best recovery I could have had. I just took 3 weeks off from work, and my job was to get better. And I did. And so this is a general breakdown of how I approach this. So my goal was to eliminate what ifs. If I can eliminate a what if, that's what I want to do. And I want to do whatever I can to stay healthy, and then as well protect future generations. So this cousin Melissa, who contacted me, she helped obviously my brother, sister, and I with this. And then I have a son and a daughter, and I have 5 nephews. So we all know to have our kids when at the appropriate age, 25 for my daughter, 35 for the boys, to get tested and then figure out how they'll proceed. So and I was actually supposed to have revision surgery where they just kind of, as I like to say, put everything back together the right way. I was supposed to have that on Thursday, but it got moved to next Thursday. So I wasn't even sure if I could participate in this, but I'm happy to be here. And then just a lifetime of surveillance is what's ahead of me. And so I'm grateful to my doctors at Sloan Kettering. These are my breast surgeon, who since left, so Sloan Kettering, my plastic surgeon on the top, and my gyn-onc on the bottom. And then on the right is my family, who's been a huge support, my sister and my brother. All 3 of us are BRCA positive. And then there's my son, daughter, and my husband, who have been there for me along the way. I can't emphasize enough to accept the support. The Temple community has been amazing. A lot of my friends are from the Temple, but everyone here in Westfield and actually around the country, anyone I know has been incredibly supportive. I've also was put in touch with a lot of different people, more than I necessarily wanted to be talking to, about women who have gone through this. But as I was processing everything and getting names and recommendations, I have some clients that work at Sloan Kettering that were helpful in directing me to doctors, and not at Sloan Kettering that were directing me to other local doctors too. So that has been a really huge support. Just to have the amount of support I had is certainly grateful. Something I'm very grateful for, and help with my mindset as I went through this. And as I said, I got this, I did this, and if I had to, I would do it all over again, because to me, it hasn't been easy, but it could have been a lot worse had I not known all about my BRCA mutation. So I'm just glad to be here to help people know that, like me, I had no idea that this could be something that's a part of my life. I never thought about it. I deal all day long with people talking about generational patterns of behavior. But again, now I know to think about the medical aspect of it personally. So thank you.
Thank you so much, Lauren, and thank you to all our speakers for this great talk. So we don't have a lot of time left, but and I haven't seen any questions come up in the box. I know Dr. Kirstein's got to pick up the kiddos from Hebrew school soon, but I have just a few questions, and if anyone thinks of anything, you can type in the box, and then just, if any of the speakers have to drop off, go ahead. But my question is probably more for Angela. Do we know what percentage of the Ashkenazi Jewish population has at least one of the, genes that you discussed? I know this is more BRCA today, but I'm wondering what percent of us has any of those.
Oh, you mean any of those mutations?
Yeah.
No, so it's
every gene has its own risk and they're not linked, if that makes sense. I'm just trying to find you back again. So I don't think we can necessarily sort of merge them into like one category. Like on the slide, as I said, well, I'll go back to my slide briefly with the Jewish mutation, the BRCA, 1% has the 185 delayed, 0.15 has the other one, and 1.5 has the BRCA2 mutation. But we can't sort of link that then with the MSH6, they're separate entities, they're separate genes. And so although there's founders, we can't sort of link that together. Does that make sense?
I understand what you're saying. Is there any use for someone who, say someone had a mom or grandmother or aunt or whatever had cancer, died, never got tested? Is there any use for someone in that situation themselves to get tested for all the genes then, just to make sure? Yeah, it's a good point. So I've had to modernize myself. We were very upset when people used to get tested when they were unaffected. This is years ago, because if you test an unaffected individual in the DNA of genes, we haven't tested everyone's genes in the world. So we could come up with these variants of uncertain significance that I mentioned, which is not necessarily helpful in someone wanting to make decisions when they haven't had a cancer and we don't know, haven't proven it's due to the cancer that was in the family, if that makes sense. Yeah. But now with things are modernizing, where we know more, we counsel people more. I'm actually more of an advocate now, not necessarily for the really big panels, but if you've got breast cancer or cancer on both sides, absolutely meet with a genetic counselor or specialist, though, who can provide you a risk assessment, determine which gene should be tested to reduce the chance of you getting some random result that's not going to be useful. Because we do pick up, I actually did recently, her mother passed away, only child of ovarian. We did the genes and she's got a BRIP1 mutation, and we found it. So that's been so important for her. But we also counseled if she had an inconclusive result, we'd work her through it. We've got databases and we don't let things lie. So I really encourage people to either update their testing, come back for a risk assessment if the family history changes, or in the setting years ago, we don't turn people away now if they're unaffected to test. I try to ask people to test in the setting of someone who's ordered these tests before, if possible. But as Lauren highlighted, and actually I didn't know this in advance, it was exactly my point when she had these 3 changes in genes. We're finding this now, and the BRCA2 trumped the other genes, right? But it's important for the family, because if someone tests negative for the BRCA2 in her family directly, they might still have ATM risk or the APC risk, right? So you've got to make sure they don't just test for the BRCA. Is that clear? Yeah, we did get one question. If you know you are positive for BRCA2, is it worthwhile to get tested for all the other cancer genes? It sounds like yes, right? Well, so we go back and forth a little bit, because we can definitely, when we've tracked a family where we've really tracked this mutation, the chance of someone having a mutation on that side of the family that is on top of the other one, it's possible. So you could say, if you're a person who wants to dot T's and cross I's, dot I's and cross T's, I'm sorry, you could do that. I had a family recently where we thought the mutation, BRCA2 Jewish mutation, was coming from the paternal side, very strong, hadn't proven it. And there was his mother died at 32, and there was a maternal cousin who was very early onset. I said, well, see if they'll get tested. They had an ATM mutation in that side, and the APC, funnily enough, and had to come back and retest for that again. So I think it's worthwhile, at least a discussion. You're not going to be made to, whether insurance covers it. Genetic counselors will work with you through that, if that's of interest. Yeah, and then we had another question of how frequently or how soon should people have updated genetic testing? So we always say, and it doesn't always happen, try to check in, especially if there's a family history and someone's negative, right? And we haven't attributed it to a known mutation. Check in every couple of years. Check in when a family history, if it changes, gosh forbid. I don't know if anyone heard or read the New York Times article on PALB2 that came out. That's another gene that links breast and pancreas cancer. We had a lot of people coming back because of that article and being retested. And that I didn't like that. Obviously, someone has a PALB2 mutation, but the fact that it was publicized brought people in. Angelina Jolie
we got slammed when that came out. And, but that's a productive situation, right? So I recommend every couple of years, look, put it this way, 2008, I started at Sloan. The BRCA testing improved by 2012. Then from 2015 to now, we've added genes to our panels. Depending on where you've gone, you might have had a bigger panel or a smaller panel. So if you've had anything pre-2015, it's definitely worth the revisit. And even 2018, you could always reach out. And then, as of now, you've probably had pretty up-to-date testing.
So I'm not trying to plug MSK or anything, but I know three out of 5 of us work there. I'm just wondering if someone wanted to get genetic tested, they don't have cancer, but maybe they have a family history of it. Would they be able to reach out to our genetics department?
Absolutely. I mean, I'm happy to see them. I can give you how would you like to, I can give the number to call for an appointment. I mean, I can see you. I do kids remote. I'm very happy to see you. You can see one of our other genetic counselors. You just need to provide there'll be a questionnaire to provide your family history, because a lot of people have questions about insurance coverage. But now that it's remote, very few people don't show up to their appointments, and very few people are upset if we don't test them because they're not going anywhere. We also provide saliva kits. It's become a lot, actually. So we take blood or saliva for testing. We talk about insurance. We'll let you know if it's covered or not. But yeah, it's always worth a discussion. I mean, I'd love for, if anyone has questions. And again, I'll plug Sloan, but I also say any cancer person any cancer hospital is great. What I do like to encourage is try not to get a local doctor who's not familiar with genetic testing to maybe test, just because you end up coming to us anyway if there's something significant or inconclusive. So I do sort of endorse that. And we work as a team. We work with outside providers, inside providers. But I don't know, I can give you the number. Maybe there's a way to give it to the audience.
We can put it in the chat box.
Yeah, I can give the number, and you can either ask me, Angela Arnold Ross, or one of the counselors to have a risk assessment. I mean, it never hurts, right, to have a discussion.
Exactly.
I just want to add to that. Can I just add something? So I did not have my testing at Sloan Kettering, but when I went, I didn't know if it was going to be thousands of dollars like I had previously heard. And it was reduced now. It's about $250, but I didn't pay anything. It all was covered by insurance.
Yep.
So I know when I've spoken with a lot of women who are, or even men, like, oh, I don't know, I don't really have a history and it's so expensive. So I'm really a huge proponent of spreading the word. Not only should you get tested, but it isn't a cost anymore.
Yeah. And honestly, I agree. It used to be, when I started, BRCA 1 and 2 testing was up to $4,000 at a lab that was only doing the testing, and insurance would usually cover it, but that's a lot of money, right? And then and then now it's down to different labs, $250. Our lab does it at a different, every lab, there's different labs, but there's all, the important thing is that was mentioned before, a clear, proper lab, a clinical lab, direct to consumer. You've got to be very careful. I'm not saying they're bad. 23andMe will do the BRCA Jewish founder mutations. They do report them. They're allowed to, that's all. But other direct to consumer, just be very careful. But we don't discriminate. Bring your results to us. Like, we will talk to you. We advocate for you. We'll review it with you. But yes, tests. Thanks, Lauren, for pointing that out. Tests are now cheaper. We get a lot of questions about out-of-pocket costs. Look, even if our test is too expensive for someone, we will say, go to outside, get it tested if you're not comfortable, and then come back with the results. Like, I just want people to test, have the right information with the experts versus worrying about a payment. But I know it's a big thing. But it's definitely not in the thousands of dollars. Like, I think we capped one of ours at $760. The GeneDx, but there are labs that are cheaper, labs that are more expensive.
You're muted, Michelle.
Mute.
Oh my God, me and technology, not a good mix. 5 years ago, when I had, when I went through all of this in 6 years ago, in 2015, that was a big thing. I mean, I had a gynecologist appointment, and I have a very close relationship with her. And she sat me in the office, and she quickly got the paperwork. And because it was a first cousin, and because I was Ashkenazi, she said, I think that your insurance is going to cover this. My sister, who got tested, she had to struggle more with her insurance. And I was very fortunate. And not only that, so my insurance, I was very fortunate because I hit those 2 marks that I was able to, insurance covered it. And also my insurance, I was very lucky. We paid minimal out of pocket that our insurance company covered it, but not every insurance company covers a lot of this stuff. So a lot of people are hesitant.
Yeah, so just one thing there with insurance companies. So we usually go by National Comprehensive Cancer Network guidelines, or a lot of the insurance providers do. Aetna's weird, but don't worry, if you've got Aetna, it'll be covered. But it can be a covered test, right? Medically necessary. But if you've got an out-of-pocket copay, co-insurance, that can be a big deal for some, unfortunately. And sometimes we don't have a say over that. So although it's a medically necessary fits criteria test, which a lot of it is, like you, Michelle, would have fitted it. The question is, do you have a deductible? We work with patients on that. We really only ask for copay, co-insurance, if anything. Some other labs do work with patients too. So, because if you think about it, insurance providers probably are upbilled because they pay so little, to these people. But yeah, out-of-pocket costs in my mind, I know it's real. I never diminish it. I prefer someone to be, and I will tell someone if it's cheaper somewhere else, I want someone to be counseled and have a risk assessment for their lives, for their family, then worry about cost. And then if they have to go somewhere else, go and then come back. Do you know what I mean? So I think if it's possible to not be flippant about it's not money, your insurance company in theory should cover it. We'll reduce your out-of-pocket as much as we can. But that's a very good point, Michelle. And things have changed too with insurances then, Michelle, as well. The National NCCN now is looking at, you could probably get an unaffected Ashkenazi Jewish individual to do the BRCA Jewish mutations in covered. Not always, won't guarantee it, but it's in the guidelines. You could sometimes get that covered, because we did a B4 study looking at the population risk, and there was a good proportion of people in the population we found mutations in that they didn't know about because there wasn't a strong family history. So in the Jewish community, we do discuss that with our patients, but that is a bit more of an issue with the out-of-pocket, but it's always discussed.
How young would you test someone? Like if someone's mother had breast cancer, would you wait until they hit adult years or over 18 or whatever it may be?
Good question. And this also lies into with Laurie as well. And I'll get her to take over the screening side of it. From a genetic standpoint, depending on the gene, it's a 50-50 chance, right? So if mom has it, now, if it's BRCA, we generally try not to test people under, say, 25, because that's when we'll start screening. And I'll get Laurie to speak to that in a second. But look, I had a 20 to 25-year-old who wants to know, it's not their parents pushing for the test. They want to know because of XYZ, and we carefully counsel the young adults. There's a lot going on, right, between 18 and 25, when we really don't start screening under 25. So, and then a lot of the time, sometimes parents are anxious and they want their kids tested. So it's not like we won't test anyone under 20, but there might not be need to, but we put a lot of support into those groups. There's a couple of genes where we do test, but that's off this topic. So maybe Laurie can speak now we really have a pretty strict guidelines as to when to clinically action a BRCA mutation. And then it's hard to tell an 18-year-old you've got a BRCA mutation and we're not going to do anything for 5 years, maybe a chest exam, and that's being flippant. You know what I mean? That's we carefully talk about these young adults.
Yeah, thanks, Angela. I mean, I think so. There have been some good studies to show that under the age of 30, we don't really want to do mammograms in young women, because actually, we don't want to do mammograms in young women under 30 because it actually increases their exposure to radiation a little bit more. So at 25, we start doing MRIs in young women for BRCA mutations. And again, like Angela said, we don't really test women younger than the age of 25 simply because of the maturity level. I mean, Michelle and Lauren can speak to being able to process this as social workers and as adults. But to think about a young girl actually having to process this, who's also still sort of coming into their own body, it would be a very difficult ask. And so we don't do that. On the other hand, if there is a cancer diagnosed in a woman with a BRCA mutation, let's say at 28, we actually might start thinking about doing it just a little bit earlier, because we like to screen 10 years younger than the youngest person diagnosed. So honestly, that should be the exception and not the rule. And I'm going to tell you, so I've been a breast surgeon for 17 years. If they I have had one patient with a BRCA mutation under the age of 25 who had cancer in the past 7 years. There was a BRCA mutation known in an aunt in the family, and it just had not tested right yet. And she did remarkably well, thank goodness, but it's very rare. So
I think, yeah, Laurie, thank you. I mean, I think there's so much talk, about the whole like genetic counseling piece, but there's a whole mental health piece that when you are the child of a person who, has a genetic mutation, BRCA mutation or another mutation, nothing happens in a vacuum, right? So me being diagnosed, me finding out that I was BRCA2 positive has impacted my family, right? It's a family, Lauren, it's a family system. And so it trickles, it trickles its way through. And so my children are growing up with an education in the house that some other people don't have. And we've had open conversations. And my daughter, she's 23. And she's spoken with her gynecologist, and she, she knows at any point in time she can go if she wants, but she just wants to enjoy her 20s. And she carries this weight. However, she did do a self-exam when she was in college, and she felt something. And whereas some other child, might have just whatever. Guess what? She got herself right over to to the ER, and she said, my mom is BRCA2 positive, and they did not mess around. And they FaceTimed me, and she got the proper testing to see that it was nothing. But that whole notion of there's a whole mental health component, and kids don't want to look. You don't want them to be grieving their 20s. You want them to be enjoying their 20s and not with, how do you manage the fear of that? So,
and it's hard sometimes too, because we get some of the parents who are anxious, right? And they want to, they're really, and you get it. I have someone who wants to test their 20-year-old for an ATM mutation where we wouldn't really start screening to 30. And she's an adult 20-year-old, but she's trying to, and it's hard because respecting her anxiety and wanting to know if the daughter actually wants to, because the daughter hasn't contacted us at all, but then, there's also reproductive risks, which I didn't really go into as well. Like if someone's going to have kids younger than 25, then they should know if they're a BRCA2 carrier or an ATM carrier because of the risk in the reproductive world. So that would be one time to test or consider testing, but not for medical management reasons. But that's great. Thanks for sharing that, Michelle, because it's very important. And we used to say we're not going to test anyone under 25, right? But we're now more open. People can get testing anywhere. And if an 18-year-old wants to know if they're BRCA1 positive themselves and would go and get it tested, a local doctor who would do it, I'd prefer them to come and do it with us. Right. And then they could be followed by Catch until they meet with Laurie or her team. We have Lisa who follows the younger ones and does the self-chest exams until they're ready to start imaging. And then they refer to Rise or, so we have a management strategy for the young ones and for the adult ones as well. I also popped in the chat some support groups for carriers of mutations, Force, Facing Our Risk of Cancer Empowered, and Be Bright Pink as well.
I want to add one more thing, or a few more things. One, adding for a resource for younger folks, there's an organization called the Breasties, and you can go either the breasties.org or .com, but also on Instagram and Facebook. So that's really good for people that are younger. But I also want to add that, speaking of the psychological component, actually, I thought my decision to have the bilateral mastectomy was psychological in that, to me, I didn't need to do it versus like the GYN surgeries. That was something more clinically, I was all but told I had to do it. But for the mastectomy, to me, it was my way of ruling out the what ifs, because I really wasn't comfortable living with. I knew that I wouldn't be able to handle every 6 months. I think every 5 months I would have been overly anxious and nervous, whereas my sister was able to manage that. It just happened to be that she got super lucky and fortunate that she found out early on the screening worked. So she, ultimately had her mastectomy, but didn't plan on it had she not needed it. But the other part is with my kids, my daughter is a freshman in college. I found out the day before she came home for Thanksgiving. And so I wanted to give her a little bit of a break, but before she came home, but it was like a dirty little secret. So I had to just to get it out. I told my kids the next day, as soon as my daughter was home, we sat them down, let them know that I was healthy, that I was going to kind of go through a rocky year, answered any questions. She did ask, what about me? Very politely and cautiously and respectfully. And I explained pretty much what we're saying now. And then as I've learned more, I've told her, but I really am doing my best not to project my own stuff, quote unquote stuff, onto her. It's really up to her when and if she wants it. Probably not if, but when, up until point. I keep saying, as long as both of my children don't have unwanted pregnancies before then, that it's fine not to know. I mean, early, prior to the recommended ages.
Yeah.
I also loved finding out, what I found out from my gyne-onc is that if they are BRCA2 positive, there are ways to not carry it on to the next generation through in vitro. And I don't know the technical name, but pulling out the bad
pre-implantation genetic diagnosis. I skipped over my slide, but we're here for you, Lauren, when all that happens. We like
to me, I'm grateful that my kids might be the 5th generation in my family and my nephews, but we could stop it there. So it doesn't need to be at my grandchildren or my great-grand nieces and nephews. So to me, it's just incredible what modern medicine can do. And that's also a huge psychological component as well, just to know that I am not necessarily, going to be, whatever, it's not going to be passed down.
Also, it's nothing you did or didn't do, Lauren, if you did.
Well, no, that I know. I mean,
but I like to tell my patients that all the time, because
I don't know if it has anything to do with that my great-grandparents were first cousins, but, or something before then. But nonetheless,
I tell my patients all the time, it's nothing you did or didn't do. But we're here to support you and your kids, and you can always have a discussion, right? You don't have to have any testing done if people are asking questions.
It's an active discussion in my house, but I just do my best not to project it onto them.
Good.
But Shell just posted also, Shell share it is also, and the Vassar Center at UPenn. There are also other great resources.
Thank you, everyone. I think we should probably wrap it up.
Yeah, thank you all for this. It was both powerful and empowering. I think it'll take a little while to process everything that we learned today. Lauren, did you want to say something? You're muted.
Sorry. So I just wanted to say one more thing, because in a comment I saw something. So my kids are 19 and 19 and 17, and we're actually getting them life insurance now, because if they are BRCA positive, we want to make sure that they have access. So that's just another thing. I don't know if that's us being ultra paranoid, but someone had recommended that to us with a different ailment. So there's just something about that.
It doesn't hurt. There's the Genetic Information Non-Discrimination Act called GINA, just so everyone's aware, for medical and employment. But you're right, with life insurance, I think it's never a bad idea.
So again, thank you, everyone. Thank you
Thanks, everyone.
Kara, Michelle, Angela, Laurie, and Lauren for putting together an amazing panel today. And we hope that this will be one of a number of programs centering on health and wellness that we'll be offering in the future. So please check emails to see what else we'll be offering. And again, thank you all for a really amazing and powerful program this morning.
Thanks for having me. Nice to meet you guys.
Thank you, everyone.